And now I get to introduce another colleague, collaborator, co-conspirator, and friend, Dr. Carolyn Sufrin, who is an assistant professor of gynecology and obstetrics and associate director for the Center for Medical Humanities and Social Medicine at Johns Hopkins University. Dr. Sufrin?
Thank you so much. Thank you all. I'm so honored to be here today with this group, and thank you to my co-panelists. I've learned so much from you in this session. I'm speaking to you today from Washington, D.C., from the ancestral lands of the Nakastia people. I am a white cisgendered woman, and I myself have never been incarcerated, but I have cared for incarcerated people. I've learned from them through research and care, and what I'll speak about today comes from those positionalities. Next. If we are to understand the structural and historical forces that shape racialized differences in maternal morbidity and mortality in this country, if we are to understand how our society has differentially devalued some people's reproduction while promoting others, then we must look to what is happening behind bars in the United States. For what happens in prisons, jails, and detention centers, so shielded from oversight, not only tells us much about these particular individuals who are trapped behind these bars, but it also tells us about how our society treats marginalized people and their reproductive well-being when no one is paying attention. People who experience pregnancy or birth while incarcerated do so at the intersection of numerous systems that have historically oppressed and traumatized reproducing people of color: healthcare systems, carceral systems, and child welfare or family regulation systems. In this talk, I'm going to provide a brief overview of the context of mass incarceration and its health implications, share some data on how many pregnant people are behind bars, provide legal and policy background on what pregnancy care looks like behind bars, describe some common pregnancy and birthing situations that incarcerated people might experience, and conclude with some proposals on how, in the words of Dr. McLemore, this could all be different. Next. So in the US, we've seen an exponential rise in the number of people behind bars over the last 4 decades, what people summarize as the phenomenon of mass incarceration due to overlapping policies and legacies of Jim Crow segregation, slavery, and all the systems of oppression that undergird our society. But in a lot of the conversations of mass incarceration, women are left out. And yet within these 4 decades, and amid this exponential rise, women have been the fastest growing segment of the incarcerated population. And since 1980, we've seen a nearly 750% increase in the number of incarcerated women. Next. That amounts to about 218,000 women on any given day and about 1.7 million arrests of females each year. The majority of these women are young, are mothers, and the primary caregivers to young children. So when they become incarcerated, it has a profound ripple effect on the children, families, and communities that they leave behind. Next slide, please. Most women are incarcerated for minor charges that have little to do with them being threats to public safety and more to do with root causes of inequity, such as racism, poverty, unstable housing, unequal education and employment opportunities, untreated mental illness and trauma, among others. And everything about mass incarceration disrupts the core principles of reproductive justice. We know that Black women are incarcerated at twice the rate of white women, but that statistical fact belies a complex intersection of forces. And when we talk about racial disparities and racial inequities in incarceration rates, it plays out in a very distinct way for women compared to men who are incarcerated in this country. And that's because of the unique and distinct and deeply problematic overlap between policies that criminalize certain behaviors in pregnancy, such as substance use disorders, rather than providing people with access to medical treatment, they're criminalized, and other policies, including hospital-based reporting policies that are enacted differentially on people of color. And the ways that mass incarceration in the US has come to be a strategy of social and racial control is intertwined inextricably with our family regulation system. And this has been delineated in great detail by legal scholar Michelle Goodwin, as well as others who have explored these overlaps. Next slide. So what do we know about how many pregnant people are behind bars? Well, we know very little. My research team at Johns Hopkins conducted a national study to collect data about just how many pregnant people are there and what happens to those pregnancies. We collected data for 1 year on a monthly basis from 22 state prison systems, from all federal prisons and 6 jails, including the 5 largest. It was impossible to study all the jails because there are about 3,000 of them, but we don't even know how many there are. And before this, there was no data on pregnant people behind bars. It's not captured in PRAMs. It's not captured in any of the relevant maternal health databases. And I want to thank Abigail Echo-Hawk for her presentation earlier and her description of the violence of these data elisions and what that does. What does that mean when we don't count certain groups of people? It means to policymakers, it means to so many people that they must not exist. And when they have that misperception, the mistreatment, the disrespect, and the oppression continues. And so now there is one small sliver of data, not only from our study, but Congress enacted the First Step Act in 2018 that now requires the Bureau of Prisons on an annual basis to report pregnancy outcomes. So what did we find? Well, there's a lot of information in this infographic, but I do just want to draw your attention to the top 2 rows that highlight the number of admissions of pregnant people. So at these prisons in 1 year, there were nearly 1,400 admissions of pregnant people. And at these jails, remember there were only 6 of them, there were over 1,600 admissions of pregnant people to these jails. So imagine what that must be on a national scale. And when we extrapolate it up, it's roughly close to 60,000 people. When we looked at the outcomes of what happened to those pregnancies, the majority, not surprisingly, ended in live births. There were very few abortions that occurred. There were also miscarriages. That was the second most common outcome. But for people in the prisons, there were nearly 800 births that occurred. That is a lot of birthing people, and that is a lot of babies who are born while their parents are incarcerated. Next slide. I do also want to add that in terms of the data that we did not collect for the PIP study, before I go into the healthcare delivery conditions, I do want people to note that we were not able to collect data disaggregated by race or ethnicity. We couldn't get the prisons to report that level of data, and nor were we able to collect data about morbidity. So there is much that is missing. I do want to also add that there were 0 maternal deaths in our study, but that doesn't mean that it doesn't happen. And again, as Abigail Echo-Hawk noted, she promoted for multi-year aggregation of data, and that would give us more information. And in fact, we know that in 2020, Andrea Circle-Bear, a member of the Cheyenne River Sioux tribe, died of COVID while she was in the custody of the Federal Bureau of Prisons, where she contracted the virus. She died while on a ventilator and days after an emergency C-section. So we need more data. We need more data. So what does healthcare delivery look like for pregnant people behind bars, and what helps to inform and regulate it? Well, very little. So there is a constitutional requirement that institutions of incarceration must provide healthcare to incarcerated people, and not to do so is considered cruel and unusual punishment, and therefore a violation of the 8th Amendment. And this was secured in the 1976 Supreme Court case, Estelle versus Gamble. But the Supreme Court, it's not their job to delineate exactly what services must be provided and the quality of that service. And since then, there is no mandatory standardization of care and no system of accountability or oversight. And so that means that the care that's provided in prisons and jails is highly variable and inconsistent. Another important policy fact is that Medicaid, when it was established, explicitly excluded incarcerated people from accessing Medicaid funds and Medicare as well. So that presents some funding challenges and makes reproductive health care, including pregnancy care, less of a priority for prisons and jails. We know that prenatal care services are inconsistent and variable, and one study by the Prison Policy Initiative found that 12 states didn't even have a prenatal care policy as part of their policies, and 24 state prisons had no pre-existing arrangements for where a person in labor would go if they needed to give birth. We also know that pregnant people with opioid use disorder do not have consistent access to medication treatment and are often forced to go through opioid withdrawal, which is harmful and far from the standard of care. And if you're pregnant and incarcerated, there are limitations that you must endure with regards to your access to nutrition and various environmental conditions. And the prison and jail environments, they're not set up to be caring environments, and they're not set up for a pregnant person to nurture a gestating pregnancy. Next slide. Now, I do want to be clear that experiences are variable, and there are some prisons and jails that do provide a reasonable level of quality standard pregnancy care, but there are many that do not. So briefly, I just want to give some highlights of what it might look like at various stages if you are pregnant and incarcerated in this country. Well, while you're behind bars, you have variable access to medical and mental health care. You may be provided care from a qualified perinatal care provider, either a midwife, certified nurse midwife, a nurse practitioner with obstetrical training, or OBGYN, family medicine physician. But in many cases, you may not. It may be a provider who has never received any training in care of pregnant people. If you're a person who's incarcerated and you have contractions, or you're having vaginal bleeding, or you have a severe headache that could be a sign of preeclampsia, you can't just call your healthcare provider or present to a healthcare facility. You rely on guards as gatekeepers for your access to care. And so they, by default, become your triage person, and they are not trained in triage. Their response should always be to call a healthcare provider, but they do not always do that. Or even if they do, oftentimes the healthcare providers at the jail or prison are not adequately trained in the care of pregnant folks and what they need. It's very isolating to be pregnant and incarcerated without your usual social supports, and people have a lot of uncertainty about what their rights are, and they have more than most of them think, although they also have a lot of their rights and their sense of bodily autonomy intentionally taken away from them. And they have a lot of uncertainty and worry about what's going to happen to them during their birth experience, and also to their children. They cannot decide when they eat or what they eat. They have to ask permission to use the bathroom. They sleep on uncomfortable mattresses. And again, they lack bodily autonomy by design of being punished in an incarcerated setting. Now, when they're taken to the hospital, hospitals are also barriers for quality and respectful care for incarcerated people. And this at baseline, since incarcerated people are disproportionately Black and other people of color, they already experience all of the baseline disrespectful care and challenges that we've heard about today. But on top of that, we know from research that incarcerated patients experience a synergistic level of stigma and discrimination. And one study of nearly 700 perinatal care providers found that stigmatizing attitudes towards incarcerated people were associated with lower intentions to provide standard of care pregnancy care. If you're giving birth in a hospital and you're incarcerated, you usually can't have visitors with you. So again, you're alone. You may be shackled in labor. There are only 34 states that have laws prohibiting this practice. But even if laws are on the books, that's not enough. It still happens because the laws aren't implemented, and incarcerated birthing people are so devalued. There may be a uniformed officer in the room during birth, and that is an extreme invasion of their privacy. After birth, some hospitals have a practice of immediately separating the new parent from their newborn. And some prisons or jails will expedite postpartum discharge so they don't have to keep paying for a guard's overtime to be stationed at the hospital. Now, there are some excellent models of doula support for incarcerated pregnant and birthing people that provide support throughout the pregnancy and birth and postpartum process. It's feasible and has high satisfaction and acceptability rates and can provide necessary support and advocacy. Now, when the birthing person returns to prison or jail, who is going to care for that infant? In some cases, there might be a family member, but in many cases, there may not be someone that she can rely on. And then the infant goes into the foster care system, already exposed to all the harms of that system as well. For people with opioid use disorder, even if they were placed on methadone or buprenorphine during their pregnancy, our research has found that the majority of prisons and jails will discontinue it postpartum. So it just shows that their concern is mainly for the pregnant person and as much as she's carrying a fetus. But as soon as that pregnancy is over, they stop the evidence-based treatment for her health and well-being. In terms of breastfeeding, we know that it's possible. There are some prisons and jails that do make it possible, but it is extremely challenging, even when all the systems are in place. And in most cases, it's going to be expression of breast milk and figuring out systems to transport that milk from the prison or jail to the infant's caregiver. There are tremendous issues and concerns regarding mental health and the trauma, especially of being forcibly separated from your newborn when you go back to prison. And yet mental health care in prisons and jails is sorely lacking. And we have little to no data about the prevalence of postpartum depression and other postpartum mental illness, but we can imagine that the rates are significantly higher. So in closing, next slide, please. Next slide. What do we need? Next. We need to end carceral births. We need to follow the lead of states like Minnesota that recently passed the Healthy Start Act that no longer incarcerates pregnant people and allows them to be with their babies for 1 year after birth. And we need to end mass incarceration. Next. Until that time, there are some actionable steps for harm reduction that we can take to improve the quantity and quality of care. Some examples are here. That includes mandatory standards of care and oversight, changes to the Medicaid exclusion policy, increasing access to doulas, reducing harm from hospitals, providing breastfeeding support, and passing and implementing anti-shackling laws. And with that, I believe I'm out of time. So thank you very much. And I'm happy to take questions in the chat box.